including things like hydroxychloroquine that might have been effective against COVID. But unfortunately, it seems like nothing has really emerged as a clear treatment of existing drugs that were already on the market and had already been reviewed as safe. And even drugs like remdesivir, which is probably one of the more effective newer medications, doesn't seem to have as huge of a positive impact as we might have hoped. So what's your take on the drugs that we've found so far, or that we've tested? And are there any treatments that you're optimistic about over the coming months?
Good. Okay, great question. Thanks, Mark. So if you look at advanced disease and early disease, we have had two advances, and this was in a randomized placebo-controlled trial, not those other types of anecdotal things which give you information that generally confuses people. If you look at remdesivir in individuals who are hospitalized with lung involvement, and you look at the impact of remdesivir, there was a highly significant but modest effect in diminishing the time to recovery. So that's one well-proven good drug. Dexamethasone, which is a glucocorticoid, an anti-inflammatory steroid, clearly showed in hospitalized patients on ventilators or requiring oxygen, but not people with early disease, that if you gave it 6 milligrams a day for up to 10 days, you significantly diminished the death rate in ventilated patients, in patients requiring oxygen, but not in early patients, which is interesting because it goes along with what we know of the pathogenesis of the disease, that when you have early disease, you want to block the virus and keep the immune system revved up and working. When you have late disease, it's less the virus doing damage than the aberrant inflammatory response, which is the reason why dexamethasone works. So we have two good things going. What we really need is your question about what do we have in the mix right now? What we really need are drugs that, when given early, can prevent a symptomatic person from requiring hospitalization or very dramatically diminish the time that they're symptomatic. And some of the promising ones are other direct antiviral drugs, which we're screening and targeting. Also, convalescent plasma, which we're doing a trial to see if it works, hyperimmune globulin, and importantly, monoclonal antibodies. Monoclonal antibodies are very precise bullets that you have by developing from a person who's been infected or vaccinated, making antibodies, clone their B cells, and give it to people early on. You can do it as an outpatient, you can do it as an inpatient. All of those things are being geared up now and are either in clinical trial or will soon be going into clinical trial.
So when you talk about things like monoclonal antibodies, how would that be administered, and who could get that? Who is the audience that might be helpful for?
Yeah, well, first of all, it can be administered intravenously. Once you get the right titration, you can do that subcutaneously or intramuscularly. You can do it for two things, Mark. Excuse me?
Through a shot.
Yeah, through a shot. Yeah, either right through the vein or just like you get a gamma globulin shot. You could do it that way. Now, that can be done either for prophylaxis or for treatment. So, for example, if you're in a situation where you have a nursing home situation where there's an outbreak and you want to prevent people from getting ill, you can just do it that way. Or after a person is infected, you can give it to them as a treatment. This was very successfully done in a randomized placebo-controlled trial. It wasn't a placebo, it was a drug that was serving as the control. You might remember, Mark, of Ebola in West Africa, where we showed that two types of different monoclonal antibodies were very effective in Ebola. And we hope we're going to see the same thing now with COVID.
And what do you think the time frame for something like that might be?
Well, the trials have already started, Mark. I would hope that as we get to the late summer and early fall, we'd be able to have enough efficacy data. Because remember, whenever you do this, they may look promising in an animal model. You always got to be concerned about safety, and you got to be concerned about, are you really giving someone something that works? So The clinical trials are underway for some and will soon start in another. I hope by the end of the summer, we'll have enough information as we get into the fall that we might be able to utilize these. It'll be really good if we have bookends, drugs for advanced disease and drugs for early disease to prevent advanced disease.
Yeah, got it. That makes sense. And if that's coming over the next few months, I mean, that's a good cause for some optimism.
Yeah.
Longer term, of course, developing a vaccine is going to be critical. So I'm hoping that you can talk a bit through where we are in that process at this point, and what the process from getting from where we are now is to having a vaccine that could be given to people broadly, and when the soonest would be that kind of a vaccine might be available.
Yeah. I'm actually cautiously optimistic about this, Mark, because of what we've seen. As you probably know, given the technologies we have and the different platforms, we moved from literally the day that sequence was put on a public database to getting that sequence, pulling the gene and sticking it into a platform to make a vaccine was measured in days. And then 62 days later, we were in a phase 1 trial. So where are we right now? There are multiple candidates, not only one. So I might talk as the prototype of one, but there are more than one that will be going into advanced trials sort of in tandem sequentially. One right now that 2 days ago, it was published in the New England Journal of Medicine, the phase 1 data, which we did some time ago, for safety and to see what kind of response it was induced. The thing that makes me optimistic about this whole enterprise is that this vaccine, which was an mRNA vaccine from Moderna that was developed here at the NIH, but as I mentioned, it's not the only one, that induced in the people who were in the phase 1 trial levels of neutralizing antibodies, which are the antibodies that are the real bullets to stop the virus. That is the gold standard of protection, is neutralizing antibodies. It induced it at levels at a moderate dose of the vaccine that were as high or higher than what you see with convalescent plasma after natural infection. And one of the hallmarks of vaccinology is when you get a vaccine, you'd like it to induce a response that's at least as good as natural infection, which would predict that the vaccine would likely be successful, even though the proof of the pudding is always, you got to do the big efficacy trial for safety and for efficacy. At the end of this month, July, we're going to be starting the phase 3 trial of this candidate. And as we get into the summer, a month later, another candidate will go into phase 3 trial. And then a month later, another. So that over the next 4 to 5 months, you're going to see sequentially these candidates going into clinical trial. Having said that, if everything works out the way we hope and we don't get any unpredictable potholes and bumps in the road, we should know as we get into the mid to late fall, early winter, but probably late fall, whether we have candidates that really are safe and effective. And I hope and anticipate that we will have one or more. If that's the case, by the time we get to the end of this year, the beginning of calendar year 2021, we may have vaccine one or more candidate that is actually safe and effective. That being the case, we can start distributing doses widely at that time. And the reason why I think we can do it is that even as we're doing the clinical trials now, we being the enterprise, the companies, are going to already start making doses at risk, which means they're going to make doses even before they know the vaccine works, which means if it works, they've saved months. If it doesn't work, we've lost a lot of money. But we figure it's worth the risk. So the risk is not in safety, and the risk is not in scientific integrity. The risk is financially to try and make these steps truncated. So that's where I think we are. So I'm really quite cautiously optimistic that we'll be able to have something as we get into the end of this year and the beginning of next year.
Yeah, that's a good note of optimism. I think it might be useful to talk through the process of vetting a vaccine, both so that people have some sense of what it takes to get from an initial candidate to something that's ready to go, but also because, while I know that the vast majority of people would be very excited and optimistic if they could get a vaccine that would prevent them from getting COVID today. I know that there are some people, it's a fringe, but it's unfortunate, who question the overwhelming scientific evidence on the safety of these. So I just think going through the process and showing how overwhelmingly focused it is on making sure that these vaccines are safe would be helpful to go through as well.
Sure. Very good. I'll do it succinctly. Well, you get a candidate like the one we did. You get it, you put it in the form to be administered, and you put it through animal studies, animal tox studies, animal efficacy studies. So before you even think about going into a phase 1 in humans, you got to have, is there a reason to believe that this is going to induce a response? You got to see it induced in an animal before you see it induced in a human. And does it protect in disease in an animal? Then you get that candidate and you go into phase 1. Very limited number of people. Our phase 1 had 45 people, 15 at each dose. You want to see, is there any immediate safety signals? And you want to see if it induces the kind of response that you would predict would be protected. Then you go to the next phase. So if phase 1 is 45 people, phase 2 is hundreds of people. You get there, you continue safety, you continue immunogenicity. If it looks good, you then move to phase 3. Phase 3 goes from hundreds of people to thousands of people. The trial we're going to start at the end of July is going to involve 30,000 people. So when you have that many people in a trial, not only are you looking to see if it works, but you're constantly keeping your eye on safety to make sure that a vaccine actually doesn't enhance disease and make people work. Once you do that, at every given point in the trial, an independent group called the Data and Safety Monitoring Board looks at the data and says, trial's going okay, you can continue. Looks next month or the month later, trial's going okay, you continue. Or, wait a minute, it looks like you're never going to really get an answer because nothing looks like it's working. You have futility, stop the trial. Or what we're hoping for, Mark, that they look at the data and say, wow, this looks good enough that ethically you can't continue with a placebo. You've got to say this works, let's start distributing it. Those are the individual steps of developing a vaccine.
Okay, that's very helpful to go through. While we're on kind of the basic safety measures for some of the common sense things that we're hoping to roll out, I have a question here asking if there are any known adverse effects about wearing a mask at all. I mean, there are some memes that go around, are people breathing in more carbon dioxide? Are there any issues like that? From all of the studies around this, has anything negative been found?
No, not at all, Mark. There has not been any indication that putting a mask on and wearing a mask for a considerable period of time has any deleterious effects on oxygen exchange or anything like that. Not at all.
Yeah, and my understanding is this has also been studied even in people when they're running and exercising and things like that. And I haven't seen anything that suggests that there would be any issue. But I mean, you obviously are the expert on this.
Well, no, I mean, I wear a mask when I'm outside all the time, particularly making sure that I don't remove it when I'm close to people. And it doesn't bother me. I even run with a mask on. Sometimes it gets a little moist there, depending on the cloth that you're wearing. But there's nothing to indicate that wearing a mask has deleterious effects.
Okay, well, it's good to just get a chance to make sure that is crystal clear for everyone. And just reading a few more questions from the thread here. One that has come up a bunch is, some people are wondering, if someone isn't showing symptoms, then how is it that they could be contagious? I mean, I kind of get why that might not be obvious to a lot of folks. So it's probably worth just taking a few minutes to talk through that and how that works.
No, that's a great question, Mark. I'm glad you asked it. Yes, and the reason you can be contagious, if you look at how you transmit from one person to another, the virus resides in the nasopharynx, in the back of the throat. So that's the reason why when you speak or cough or sing, the virus in droplets comes out. You may not see it, but when you do certain lightings and lasers, you can see it. What we have found out that when you measure the level of virus in the nasopharynx of asymptomatic people compared to people who are symptomatic, there doesn't seem to be any difference, which means there's as much virus in the nose of a person who's asymptomatic as there is in a symptomatic person, which means it is very, very likely that when that person talks or sneezes or whatever, that enough virus will come out to infect someone else. So there is not a lot of difference in virus load, even though people can be very different with regard to their symptoms.
Yeah, so related to your point about droplets, there's some recent pieces that I've seen suggesting that or wondering whether, to the extent to which this is aerosol or droplet. There's a question from the thread about, do we have any data on how this moves around differently inside versus outside, or how long this can linger in the air for?
Yeah. Okay, so the linger in the air question relates to whether or not it's aerosolized, or another word people use is airborne. So there are different types of droplets. So most of the droplets, when people speak and you see that little spray come out, are greater than 5 micrometers. Those are the kind that they're heavy enough, Mark, they don't go any more than 3 feet, at the most 6 feet, which is why we say when you're outside, stay at least 6 feet apart from someone. There are other droplets that are less than 5 micrometers. Those are the ones that can, quote, aerosolize. And aerosolize means instead of coming out from your mouth and dropping within 3 to 6 feet, it can kind of float around the air and stay in the air for a period of time. Right now, it is unclear, and it is because we don't have enough data, that there is likely some aerosol that comes out. And you could show that by these lasers and lights. We don't know the extent to which aerosolized or virus that stays in the air for a long period of time is involved in the transmission. We certainly would like to know that, but it's very difficult to determine that, even though we know that some degree of aerosolization does occur. If you turn back the clock and go to SARS back in 2002 and 2003, there was a clear-cut instance in a Hong Kong hotel where aerosolization absolutely occurred, spread through different floors, and infected individuals. Why that person who was the source of the aerosolized, or whatever the source was, we still haven't figured out. But that was a good example of a coronavirus spreading through aerosol. But right now, today, I can't tell you with scientific certitude what proportion is spread through aerosol. That's one of the unknowns we're just going to have to work out.
Got it. Okay. Maybe go back to vaccines for one more minute. I mean, we're trying some novel strategies with some of these vaccines, like the RNA vaccine. I think the Moderna candidate might be an RNA vaccine, and I'm not sure if there are any. This might be the first kind of major RNA vaccine. So I'm curious to just hear you talk about the advantages and disadvantages of the different strategies for types of vaccines that can get developed, and maybe even beyond COVID. If an RNA vaccine ends up being possible and working, what are some of the advantages for treating future outbreaks and things like that in the future?
Yeah, good question. So there are multiple, we refer to them for your listeners and viewers as platforms. So mRNA is a platform. Viral vectors are a different platform. Soluble proteins, recombinant proteins. Killed inactivated is another platform. So we had multiple platforms. There are 3 that are being actively done. One is the mRNA. The other is viral vectors, where you take a virus, stick the gene of the spike protein so that it expresses itself, and then you get an immune response when you inject that. The other is just taking a protein and inject it with an adjuvant. The reason that the novel technologies we used that were very easy to just get out of the blocks and go with it, test, assess, what I explained to you, the timetable. We went from a couple of days, bingo, into a vaccine, done. So if it works, which we believe it will be a major advance of ease, of facility, of scale up, and ultimately of cost. We'll do it. It hasn't been proven the way some of the others have been by years and years of experience. So that's one of the things. If it works, which I hope it will, I think it will, people will be saying, wow, we have a red hot platform here. We're going to start using that for a lot of other vaccines. The other ones that we have are the viral vector ones, the ones I described, be an adenovector, a vesicular stomatitis vector. That's another one that we've had some experience with, particularly with Ebola, in which it worked very well. And then there's the ones that have been used more commonly, which is the soluble proteins that you can make with recombinant DNA technology. So there's multiple platforms. We're hoping, and I believe we'll be successful, I hope we are, that more than one of them will prove to be safe and effective. It'll be good for the effort, and it'll be good for the field of vaccinology, because it's really unprecedented that we have so many different platforms going on at the same time to determine safety and efficacy.
Yeah. All right. So I think we're almost out of time. So I wanted to check in and see if there's anything else that you wanted to cover, or are there any other thoughts that you'd like to leave this community with?
Yeah, I just want to reiterate what I said before, Mark, and thank you for giving me the opportunity to say it, that we are all in this together. We are going to get through it. We will get through this difficult situation. At best, it's difficult. I mean, it's a very significant issue that we're dealing with right now, but we've all got to do it together. We're in it together. And since I know we're looking disproportionately to a lot of young people that are watching this, please assume the societal responsibility of being part of the solution and not part of the problem. Because we're going to get through it. We're going to get this under control in the southern states. And hopefully we're not going to see these kind of surges, so that we do get down to the baseline that we hope we would. Because once we're down to that baseline, Mark, it's going to be so much more easy when you open up the country, as it were, to put your clamps on when you get individual infections. They don't soar off the ceiling. They stay clamped down. That's the message I want to get one last time.
Great. Well, thank you, Dr. Fauci. I think I say this on behalf of millions of Americans who will watch this. We appreciate your leadership and your dedication to helping us navigate this. You have a lot of people's confidence, and a lot of people out there continue to have faith in science and want to make sure that this is led, that our response is led by science. So thank you for everything that you are doing in what are some trying circumstances, and please stay healthy and good. And thank you to everyone out there for tuning in today. I hope you all stay good as well, and I'm looking forward to seeing you all soon.
Thank you, Mark. Thank you for giving me the opportunity to be with you. I really appreciate it. Thanks.